Today's event is hosted by the USC-Brookings Schaeffer Initiative for Health Policy, a collaborative effort which I direct between the Schaeffer Center at the University of Southern California and the Brookings Institution. And I'm pleased that among our guests today is Leonard Schaeffer, who was a trustee of both Brookings and USC, and also supported the establishment of this initiative. Mr. Schaeffer will be providing closing remarks later this morning. Today's program takes on the opioid crisis, which is ravaging almost every corner of the country. The CDC estimates that 91 Americans die of an opioid overdose each day. We will look at the policy approaches to this epidemic and the underlying issues associated with it. Our keynote speaker is Sir Angus Deaton. Sir Angus is a perfect speaker to help us understand the underlying issues that have contributed to the opioid crisis, as well as increased rates of alcoholism and suicide among certain segments of the American population. Sir Angus is the Dwight D. Eisenhower Professor of International Affairs Emeritus and Professor of Economics and International Affairs Emeritus at Princeton University, where he is currently a senior scholar. He is also the Presidential Professor of Economics at the University of Southern California. In 2015, Sir Angus was awarded the Nobel Prize in Economics. His current research focuses on determinants of health in rich and poor counties in the United States and around the world. We also will hear from Professor Bertha Madras, who was a member of the President's Commission on Combating Opioid Drug Addiction and the Opioid Crisis, and will give us some insights on the Commission's report, which was released on Wednesday. Professor Madras is Professor of Psychobiology at the Harvard Medical School. I also want to take a minute to introduce today's moderator, Alan Weil, who was Editor-in-Chief of Health Affairs and the Director of the Aspen Health Strategy Group. Alan is a perfect person to shepherd us through this discussion, given his extensive work on the opioid process with the Aspen Group, something I've seen up close as a member of the group, and I thank him for being with us this morning. Now it is my honor to introduce our first speaker, the Honorable Ann McLean Kuster, Congresswoman from the 2nd District in New Hampshire. She also serves as the House's co-chair of the Bipartisan Heroin Task Force. This task force has worked hard to increase interagency collaboration to better address addiction, and they have successfully helped pass 18 bills that became part of the Comprehensive Addiction and Recovery Acts. She has held hearings and events here in the Capitol and at the local level to educate lawmakers and the public about effective ways to address this crisis. I'm grateful that Congresswoman Kuster has made time to join us today on her way to the Capitol for some votes this morning. Congresswoman Kuster. Thank you.
Well, good morning. It's great to be with you. I wish I could stay for the entire program. We do have votes coming up, but it's a tremendous honor for me to be with you, and congratulations on the work that you're doing, both of you. And we need everyone to come together. This is the most complex issue. Every time you try to run down one angle on it, I keep saying to myself, I want to go upstream, 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 and then you realize that it's just one big circle where you're, dealing with pregnant mothers with babies born with neonatal abstinence syndrome. And you can't get any further up the stream than that. And it just brings together everything, the healthcare delivery system, the economics, the influence of insurance in our lives, the influence of the pharmaceutical industry in our lives, and then obviously all these cross-current economic and cultural issues that are going on in our society right now. So I'm very pleased to be here with the USC-Brookings Schaeffer Initiative, and thank you very much for having that on health policy. and focused on incredibly important issues, strengthening Medicare, improving the Affordable Care Act, which is high on my list, and now focusing on the opioid epidemic. I'm so delighted that you're turning your attention to this, because this opioid heroin epidemic is literally tearing apart our families and our communities from coast to coast. It's particularly troublesome right now in rural communities, and there's a whole theory behind that of the Mexican drug cartels targeting rural communities so as not to have to compete with the urban gangs and with law enforcement. And you can literally watch, I've had DEA briefings that are sort of time-lapse slides and maps, and you can literally watch this travel up our interstate. In my part of the country, this started in Ohio and West Virginia and Kentucky, and then up through Pennsylvania and New York. It came to New England, and you can watch over the past 5 or 6 years going up I-91. Vermont was hit very hard, and the communities in the western part of my district on the Vermont border were hit hard. The first time I heard about it was a story in a little town called Keene, New Hampshire. There's not a more quiet place on this earth, and a beloved high school teacher, mother of 3 children, died of a heroin overdose. And it just, we were so shocked to hear this story, and for that family to have the courage to say that that's what it was. And you'll see death notices now that are much more honest and deliberate about saying what's going on. But then it went up I-91, and then later it came over through Lawrence and Lowell and up I-93 if you've been in the White Mountains and the beautiful lakes of our state, and then eventually up I-95 and all the way up into the farthest reaches of Maine. And this is spreading throughout the country that way. And I talked to my colleagues in West Virginia and Tennessee and Kentucky, and now I'm starting to talk to my colleagues in the Midwest and the northern Midwest, and then finally out on the coast. So I'm really delighted that you're focusing your attention on this. I think it's something that is an epidemic. It is an emergency. We've been urging the president to declare an emergency, and now he has. But we need to make sure that we have not only the policy, but the resources behind this to actually make a difference in people's lives. So the most recent data, 2015, over 50,000 Americans died of drug overdoses, and we know that's growing literally exponentially in some places, a rate that now exceeds automobile deaths. You'll remember back, I said to a group of young staff, I remember automobile deaths before seatbelts. This happened, and we can do this. We can turn the tide on this. Over 30,000 of those drug deaths were due to opioid-related overdoses. New Hampshire, my home state, we vie with West Virginia. They're number 1 for opioid deaths, heroin deaths. We're now number 1 for fentanyl. Fentanyl is this new synthetic substitute, and it's even more lethal. And in fact, it's just a lethal cocktail is what happens. People get it in a dose that they are not prepared for. The dealers don't really, obviously, there's no FDA, nobody's measuring, nobody can tell. And so they take what they think is going to be heroin or perhaps some fentanyl, and it'll be 100% fentanyl, and they're just dead on the bathroom floor. And I've met so many families, so many people that this has happened to. So we're now number 1 in the nation in per capita fentanyl deaths. And we take pride in being first in the nation in many things, the presidential primary and tourism and many others, but this is not the notoriety that we want. And so the complexity of this crisis is well beyond the capacity of any one state or any one community. We need a nationally coordinated response. It's a crisis that transcends politics. I say to my colleagues all the time, the opioids, the heroin, the fentanyl does not choose R's and D's. We have to come together. And I am proud to say it's one of the very rare issues where we have come together. In 2015, I joined my then Republican colleague, Frank Ginta from New Hampshire, to found what we called, at the time, the bipartisan congressional task force to combat the heroin epidemic. Now we just call it the opioid task force. And we now have 100 members of Congress, evenly split R's and D's, working together on a weekly, daily, monthly basis. In the spring of 2016, our task force helped to push for passage of 18 bills that then became the House version of what was melded into the Senate Comprehensive Addiction and Recovery Act. And you're probably familiar with that. We literally called it Heroin Week, and we did all of these bills in 1 week, and I want to commend our leadership on both sides of the aisle for the attention and dedication to that. Last December, we worked hard over the fall to help secure $1 billion in funding that was a part of the 21st Century Cures legislation, and it was a great honor to come down. I think it was probably the last bill that President Obama signed, but it was a great honor to be with my colleagues and to see opioids and the opioid epidemic take that role in the 21st Century Cures bill. And that's some of the funding that you read about, but it's certainly not enough. We continue to raise public awareness through hearings and roundtables. We have presentations by the CDC, the DEA, the NIH, and addiction recovery experts. And we'd be happy to talk with you about scheduling different events. But we'd be eager to particularly work with Brookings on future hearings. And I'm just going to put in a shameless plug for having a Brookings Fellow in my office to work on this issue. Going forward, we're exploring how we can encourage innovative programs in communities throughout the country to combat this public health crisis. And our next hearing coming up is going to be focused on turning our attention to how we move forward. We have an incredible program in New Hampshire called Safe Stations, and you might have heard early on about Gloucester, Massachusetts. But what this is that people in addiction, in active crisis, can come to our fire stations in Nashua, New Hampshire, Manchester, New Hampshire, and other communities, and present themselves with no legal consequence. And that's really important. This is so tied up in the law enforcement side and the public health side. And we need to try to work together, and we've brought people together so that our hospitals sit at the table with our fire departments and with our police and with our schools and with our business community and with our mayors. Every community has to have their own response because they have local resources that they can draw upon. But when someone comes to the fire station and presents themselves needing help, they will be processed and make sure that they are safe, and then they will be immediately transferred into the hands of a nonprofit organization that specializes in treatment and addiction recovery. And we can get these people into the resources, get them access to the resources that they need. And I've got to say, without being partisan, I'm stating a fact, that we could not do this without the Medicaid expansion, that this program would not exist. Of the first 100 people through the door, 90 of them were eligible for Medicaid expansion, and they didn't know that they had access to treatment for their health problem. And I think that's at the core of what we're dealing with. People don't realize that they can get help. They're not waking up in the morning choosing this, trust me. And so we get them into treatment and long-term recovery. This is the other thing that we need to recognize. A 28-day program does not cut it. It can be a start. We need to detox. We need to get people started down the path to recovery. But nowhere else in the healthcare delivery system would we say to a cancer patient, we're going to give you treatment for 28 days, and then you're on your own. And nowhere else would we say to a diabetes patient, and if you relapse, if you eat cake, we won't treat you anymore. What we say is, this must be a really difficult disease. Eating cake is really tempting, and it's not healthy for you, and you can't have cake. And we're going to help you deal with that, and we're going to help your family help you deal with that. But this has become emotional for me. It didn't start out that way. But 3 years into this, dealing with legislation, dealing with coalitions, dealing with my colleagues, dealing with education, I learned that my own brother on the West Coast is now in active addiction. And I'm happy to say he's in recovery. This happened to him. And I say that because he didn't wake up in the morning choosing this. He had a long series of surgeries, and he was on very potent opioid medication, OxyContin and oxycodone, starting last September 11th, I'll never forget the date, and going all the way till April. And luckily in May, we were able to get him into treatment. And now he's in recovery. But I say in recovery, this is something that we'll be living with for the rest of our lives. And it's very difficult. It's difficult for his family, it's difficult for his friends, and it's difficult in his community. This is a 66-year-old man. He's a successful businessman. He has a business of his own. He works hard, and he's worked hard his entire life. But I think he probably fits right into your research, because he lives in a very small community way up in the mountains on the West Coast, and it's difficult there. Life is hard there. He said to me, there were mornings I couldn't get out of bed because my body hurt so much, and I took the medicine that the doctor recommended. So that's where we are. We've got a long, long way to go. I do have staff here that can pass out our legislative agenda, or you can find it on my website, kuster.house.gov. This is the second iteration of our agenda. We've got bills such as Jesse's Law, helping doctors have access to consenting patients' prior history of addiction in order to make fully informed care and treatment decisions. The Stop OD Act to expand educational efforts to prevent opioid abuse, promote treatment and recovery, and encourage understanding that addiction is a chronic disease while providing improved access to naloxone and training in the administration of naloxone and testing for fentanyl. I want to say everyone is coming together and stepping up. I was on the phone yesterday with Dr. Collins from NIH. They have an incredible program that they're working on. But we need resources and we need funding. Already we've been successful this year in passing the Interdict Act, giving $15 million to U.S. Customs and Border Protection to fund new screening devices, laboratory equipment, facilities, and personnel for the latest in chemical screening devices and scientific support to detect and intercept fentanyl and other synthetic opioids, because this is a challenge. We've got to work with law enforcement. We had a hearing on synthetic opioids, and it was chilling. There are criminal chemists in China that are one step ahead of our DEA every day. We look forward to working with leadership in both parties. We understand that there is an intention to have another opioid week of legislation, hopefully between now and the end of the year, and we'll look forward to working with them. And again, I have to bring up the issue of funding and resources, because we need to make sure that not only do we declare this as an emergency, but that we put the clout behind it. So we're looking forward to a targeted response in New Hampshire on this fentanyl crisis. It's having such a deadly effect, and we're working very closely with DEA and coordinating our efforts. But finally, I just want to close by saying I appreciate your interest. I appreciate the work that you're doing. So many people have to come together to help solve this because of the complexity. And if you have suggestions for us on issues that we should be tackling, my colleagues are totally open to learning more about this. I think it has helped to have law enforcement come together with the medical and public health community. Every fire chief, every police chief in New Hampshire will tell you we will not arrest our way out of this. But we do need to work together, and we need to work on where the drugs are coming from, whether it's legitimate means or illegitimate means. They're coming from both places. We need to work on education and prevention, and then we need to work on treatment, access to treatment, and long-term recovery. And I appreciate all that you're doing and all that you're learning here today. I appreciate Brookings for taking this on, and thank you again for the Schaeffer Institute. We're very grateful to you. Thank you.
He's already been introduced, but it's my pleasure to introduce Sir Angus Deaton to give the keynote address this morning. Come on.
Thank you. Thank you for the kind introduction, and it's wonderful to be here again. One of the things, if I can echo what Congresswoman Kuster said, I think one of the things that I find most encouraging in what is a very, very bleak landscape is the extraordinary extent to which people are talking about this. And it's sort of moved into the public debate in a very, very serious way, with long form, short form, everything sort of pouring out on all aspects of this. And I think that's the way, in the end, that we're going to come to terms with this, because the community is going to have to come to terms with it locally, nationally, and everywhere. I want to talk about the epidemic in context today. I'm going to leave to Professor Madras to talk about some of the recommendations that have come out of the task force and the immediate policy things. I just wanted to talk a little bit about some of the background. It's clear that stopping overprescription and better treatment for addiction are absolutely key priorities today, and Professor Madras will talk about that. I do just want to emphasize that there are no easy solutions to any of this. There's a lot of political pushback to various forms of control. Many docs and patients believe that pain is undertreated in America and not overtreated, and there's still a lot of pushback coming from that. Letters in the medical journals, letters in the newspapers, and this is something that we've seen before. I mean, in fact, the history of pain in America over the last 200 years is one of oscillation between not treating it and overtreating it, and you know, that we can learn from what's happened in the past there. We should also know that treatment for addiction is not very effective. And, you know, that's not a counsel of despair. It's just a counsel of realism, that you should not expect magic bullets from drugs or treatment or other way of doing it. Many addicts do not believe they are addicted, do not seek treatment, or do not adhere once they're treated. There's a high probability of relapse among those who are actually treated. And the evidence, which is often pushed on us they say we have evidence-based treatments that work, that evidence is not particularly strong. I mean, it's certainly there. These treatments work for some people. They work for the people who've been in the clinical trials. They're a selected sample, and there's still high relapse rates. So treatment is better than no treatment, but it's not a magic bullet. This is not like if we suddenly get these centers out there and bring everybody into them, this will go away. This is going to be a long, hard row ahead. Many of us are concerned by turning a largely pharmaceutical-induced epidemic into another pharmaceutical-solved epidemic. And that doesn't necessarily mean that pharmaceuticals don't play a role in this, but there are dangers there too. So my belief is, before I go into this broader context, that in the end, national and local communities will indeed bring this epidemic under control, just as the crack epidemic was brought under control 30 years ago by the communities who'd essentially said, we'd had enough of this. This is not going to happen anymore. And, you know, it's stories and accounts like we just heard from a congresswoman that will really help on this, because, you know, once it's your favorite high school teacher who's dying from this, you begin to realize there's something very seriously wrong and we have to do something about it. Let me talk a little bit about the broader context, because I want to move, I'm going to let others, and we'll talk on the panel about opioids alone, but I want to talk about some of the other things that have been happening in the background. And a lot of this comes from work I've been doing jointly with my colleague Ann Case at Princeton. I just want to remind you of what usually happens to mortality rates. These are the mortality rates for white men and women in the United States aged 45 to 54 for the 100 years from 1900 to the 2000. And this is sort of a very familiar picture. of constant improvement, mortality rates going down. And this is a mixture of science and public health, people quitting tobacco, and better tackling of heart disease, a lot of prevention, so on, especially in the 70s. You can see there was a sort of flat patch there in the 60s, which was mostly to do with smoking. You can see the flu epidemic at the end of the First World War. So nothing smooth here, but there's this enormous dominant trend over a long period. These are all-cause mortality, so this is not just from opioids or anything else, it's from everything taken together. And then if you look at what happened after, I mean, if you go back to that slide, you'll see that it started at 1,400 per 100,000 deaths and finished up at about 400 per 100,000 deaths. So we're entering the new century, the new millennium, with mortality rates of around 400, and you can see them in this picture here, in which the red line is US whites, non-Hispanic whites, and the other lines show other selected countries. We just picked those because they look nice on the graph, but you could pick any other rich country, and they all sort of look like this. There's France, Germany, the UK, Canada, Australia, and Sweden. We tend to call those Europe, which is a little odd, given Australia's Canada in there. But also look at US Hispanics, and US Hispanics have continued for mortality to fall about 2% a year, where US non-Hispanic whites have sort of turned around. There are no African Americans on this picture, and the reason is it's hard to fit them on the graph, but I can tell you what's happening there. The mortality rates for African Americans in the United States over this period have fallen quite rapidly, more rapidly than even US Hispanics. But even at the end of their period, they're still higher than white non-Hispanics. So there's been a lot of convergence there, but blacks are still doing worse, even though they're making more progress in terms of mortality. The other thing that's happening, and it's a very important part to see the opioid crisis within this framework, is that heart disease has stopped falling. And this has been the great driver of mortality decline over the last 50 years, is mortality from heart disease. And you can see that for US whites, it's continued to fall, and in the last couple of years, it's flattened out and actually turned around. And it's not because we've already driven it down to lower levels than all other countries. You can see that other countries are continuing to decline, and they are doing better than we are. So there's a big problem there. And that might be part of the pattern of deaths of despair. If this is obesity, which many people think it is, then we've got obesity. Overeating is sort of like drug addiction and so on. These are behavioral irregularities that are doing bad things to people's lives. So when we found this, we then went, this is when we discovered about opioids, because we came into the opioids this way. So we looked for the things that were driving up mortality rate most rapidly. And the three most rapidly rising causes of death since the turn of the century are accidental poisonings, which means drug overdoses, suicides, and alcohol-related liver mortality. So it's drugs, alcohol, and suicide. We think of these as all being suicides in some way. I'll show you the relative sizes of these in a minute, but it's sort of like you can do away with yourself quickly with a gun, or you can do it more slowly with drugs, but still pretty quickly. And you can do it more slowly still through alcohol, excessive alcohol consumption. And what you can see here is it's not just people in middle age. This is happening to all age groups. The 50 to 54 group at the top is the highest, but 55 to 59 is not far behind. And even the elderly are doing pretty well in other respects. This is rising, and young people too. So this is happening throughout the distribution. It's just that all-cause mortality is not going up in these other cases because of the background of heart disease, for instance. And also, there's not that many deaths in those the younger groups in particular. Here's a crucial slide, which is if you split this up by education group, the people who are really being affected here, and this is true of all these studies, people who do not have a BA. And in fact, the blue line for men and women. The red line on top that are rising are for women and men with a high school degree or less. The people at the bottom are people like the people in this room who have a BA, and that's really not happening to them. These are what we call deaths of despair, which are drug, alcohol, and suicide mortality. Now, this next slide says it's not just drugs. So you can see that drug and alcohol poisoning, top left, suicide on the right, and alcoholic liver disease on the bottom left, and cirrhosis on the left. This splits it by high school, some college, which means like an associate degree, and people with a BA or more. So that's about a third of the population. And those groups have been stable over this period. So it's not like there's big compositional changes in the educational background of the population. And so you see very clearly for all three of these, drug and alcohol poisoning, which is basically opioids, is what you're looking at here. The BA or more are still going up here, but it's nothing like the people who have high school or less. That's one of the reasons why this has been so rural, because education depends a lot on rural versus urban. But there's also been a lot of targeting by the pharma companies and by the distributors of where the pain is. And a lot of this is pain connected, and a lot of it is, less educated people who are in jobs where injuries are more serious, where pain is more serious, where life is really much harder. And opioids have been very heavily used in that community. But you can see from the numbers, the drug and alcohol poisoning is about 60, suicide is about 50, and alcoholic liver disease is about 50. So of the three deaths of despair, and we're not saying anything about obesity or heart disease here, the opioids is the largest part of this, but it's less than half of the total. So, that's where, and we like to see these three things together. It also helps to put the three things together because suicides, it's not always clear whether someone intended to kill themselves or not. And if you put the opioids and the suicides together, you don't have to make that sharp distinction. The other thing is here's urbanization. And it's not true that this is primarily a rural epidemic. It is true that compared with previous drug epidemics, it is a rural epidemic. But you can see here, these are the various levels of urbanization. The lowest one is large fringe MSAs, which is where the well-educated people live, up and down the east and west coast. And then large central MSA, Baltimore City is now the highest, one of the highest places, not just West Virginia, and so on. And you can see but it's been rising more or less in parallel at all levels of urbanization. And this is my second last slide. This is what we call the two Americas slide. And this is, to us, the most troubling slide of them all. These are deaths of despair, so there are three causes of disease together. And what these look at is each line is a birth cohort. So it's the group of people born in a particular year. And the older cohorts, the earlier born cohorts, are the right of the picture, and the younger cohorts are on the left. So you're moving to younger people as you move from right to left. The right-hand graph is for people with a BA or more, and the left-hand graph is people for high school or less. So if you look at the right-hand one first, you can see that it rises with age over all these cohorts. But these birth cohorts are more or less all on the same track. So that, cirrhosis, it takes a while. You got to drink a lot, and that takes years, and you get older before you die of that. And and suicide traditionally, all the way back to Durkheim, rises with age. So we think of this as almost a natural pattern, that as people get older, they are more likely to succumb from these deaths of despair. But there's no great difference over later born and younger born cohorts. But if you go over to the left-hand side, there's just this horrendous picture. That this pattern, if you look at the ones, the cohort born in 1945, 35, 40, 40, we've only done every 5 years here, otherwise the picture just gets too messy. But you can see there's fairly gentle rise, fairly low level. You get to the birth cohort in 1950. These are people who entered the labor market, you know, around 1970 when the world started to come apart for working class people. You can see the level is much higher. And not only is the level much higher throughout life, but as you get older, it gets worse. And it gets worse faster than the younger people did. So the slopes are getting steeper. And look at the one for 955, that green one. It's way higher and it's tipped up even more. And that goes on and on and on. So for every birth cohort, this progress with age is getting worse and the level is getting worse. This is a profoundly pessimistic picture because elderly people in the US are now doing pretty well. But these people are going to be elderly soon. And if you believe this sort of what this picture is telling you, then there's real trouble ahead. Here's my last slide. The long-term decline for people without a BA. This is very, you know, provocative. Maybe it's not true. But it's the sort of explanation we've been working with. There's been a breakdown in the implicit social contract between labor and capital that existed from the 1940s through the 1970s with health insurance, minimum wage, the Treaty of Detroit whereby monopoly profits were sort of shared with labor. And that's really sort of happened. The loss of real wages have fallen for these people throughout this period. The loss of unions, which offered wage and other benefits, better social life, local and national influence, huge decline in marriage, rise of cohabitation and out-of-wedlock childbearing, the loss of traditional supported religions in favor of individualistic evangelical religions, rise in disability, decline in labor force participation, increasing levels of pain, increasing social isolation. All of those have been tracking up together for these less educated people. Anne likes to use the phrase that opioids in the 90s were like taking a loaded gun into a suicide ward. So we think a lot of these deaths would have happened without opioids, but have been made much, much, much worse by the opioids. So somehow, if you want to get out of this, we need better economic policies for ordinary Americans. We need to be able to share and not just let it all go to the top. Thank you very much.
We have time for a few questions for Sir Angus. Stand, hold up your hand. Let's get a microphone to you so folks can hear, and please introduce yourself as you ask your question. It's coming right behind you.
Of teachers. Is this on? No. I'm here? Okay. And so as somebody from a union, I really welcome that final analysis, which you don't hear. We represent nurses as well as educators who really are on the front lines. But one of the things you said that was most interesting to me, people have talked about big pharma, but you really implied some very direct marketing into poorer communities. Can you elaborate on that a little bit?
Okay. Sorry, the simple answer to that is you can watch it on your television, which I did 2 days ago. If you look at the 60-minute program on what the distributors did and how they worked with Congress to block the DEA and how the marketing was targeted at such areas. But the Congresswoman referred, she didn't call it that, but Sam Quinones has this terrific book called Dreamland, which draws a parallel between the drug industry and the Mexican cartels, which is incredibly informative too. But there were pieces in the New Yorker last week, in Esquire the week before. There's a torrent of this stuff coming out, and I think the deliberate targeting is very, very clear. And in fact, the attorney generals of a bunch of states, led by Mike DeWine from Ohio, are going after the pharma companies in the same way they went after the tobacco companies for creating this epidemic.
We have a lot of people, so I'm going to hand the mic over there, and then we'll come to the aisle here.
Sorry, maybe we could talk later. I'd be happy to.
Martin Blank with the Institute for Educational Leadership. Professor, you talked about people recognizing the opioid crisis, but it seems to me that nobody's built the bridge that your presentation suggested, which is this is part of a very deep economic crisis in the country, and opioids are fueling that. We don't seem to be having, we have these siloed conversations that don't recognize the connection between these issues. Would you comment on that, please?
That's the line we've been pushing. And, you know, we wrote a Brookings paper that was delivered here in the spring, which is available on the Brookings Papers for Economic Analysis website, which essentially talks about that. There's a fair amount of pushback. And, you know, it's hard to nail it as to whether it is this broad economic decline. But we're finding that more and more convincing. And we think it's not just economic conditions. It's really working through the destruction of a way of life for working class Americans that used to exist. I've been using the analogy of the Plains Indians. You know, they had a life which you might have liked or might not have liked before Europeans came to America, and that life was destroyed and was never put back together again. I think we're seeing that for the American working class over the last 40 or 50 years.
Yes, good morning. Thank you very much. I'm June O'Connell. I'm originally from Wisconsin and have strong ties to sort of a manufacturing, semi-rural area of the state. And when you hear healthcare, health policy people, they will say, oh, we're getting healthier. People are living longer and we're getting healthier. But when I go back to Wisconsin, I have the family members who spent 25 years working in mills. Their back hurts, and they can't shift to working at Lowe's because that's backbreaking too. And so as they've aged, they really haven't gotten healthier. So there's this myth, I want to ask you about that, somehow manufacturing jobs were healthy.
I think the manufacturing jobs were very tough, but a lot of the jobs that people have taken when they dropped out of $28 an hour jobs to $7.50 an hour are very unhealthy too. This question about whether Americans are getting healthier or not is very contentious and is divided right and left. You know, if you go back far enough, it's clear that we are healthier now than we were. But you're getting these U-shaped things that I showed here, that there's been improvement for a very long time. It's very unusual in any population in the world for mortality rates to go up and for life expectancy to fall. The AIDS epidemic, what happened in the Soviet Union is one example. The Great Leap Forward, you know, the Holocaust, I mean, you just have to talk about these things to see about how unusual and horrendous we're talking about these things. What you focused on is very true too, and you see it in the data, and in our Brookings paper we talk about that a lot. There's been a huge increase in morbidity, especially in middle age, a lot more pain. There's a lot of controversy as to whether opioids in the long run actually cause pain, make it worse as opposed to curing it. But yes, it's pretty bad out there.
So we'll have a panel later, and we have time then for only one more question. Get it back here. Mike's coming to you.
There you go. Hi, my name is Michael Manganello, and I work in the health policy field. And I noticed over the past 2 days, I do a lot of work with the FDA and the NIH, that two different drugs I completely agree that the pharmaceutical industry has created the problem, but two different pharmaceutical companies actually advanced drugs, buprenorphine, in different ways to, you know, for people to take them. I'm just curious about your thoughts about MAT and pharma maybe being part of the solution since they cause the problem.
Yeah, I mean, I think it's always a mistake to tie too closely solutions to problems, you know. And I also, you know, I'm deeply distrustful of the pharmaceutical companies based on their record. And the idea that we would turn to them to fix this problem, it bothers me a lot. But that might be just wrong. And I'm sure those drugs, Boop and methadone and so on, have a place to play. But there's a lot of journalism out there that I find very hard. I mean, you know, AA has been wrestling with this problem for a very, very long time. And it's almost impossible, and we've tried to find out, but you just can't document. AA has no one in charge. You know, by their very nature, they will not tell you how many people come in, how many, you just can't document their success rate. But I suspect AA is about as good as those drugs. And there's a lot of journalism out there saying, you know, we have evidence-based medicine in favor of pharma, and no one has any evidence-based medicine in favor of 12-step programs. And I think we ought to be very careful of that, too. Thank you.
Okay. Thank you. And as I say, we will have a panel later with a significant amount of time for audience engagement. So now it's my opportunity to introduce to you Bertha Madras, already been introduced by Paul Ginsberg, so I'll turn over the mic to you.
Thank you.
This is the first time I've ever had my slides on a window grid line. Can you get rid of? No, it's because the. Thank you very much for having me. The title of my talk is obvious. It's been made in America. Will it fade in America? This crisis. These are my disclosures, which I generally speak of before any presentation. What I'd like to present very quickly today, in the brief time that I have, is the national trends on the opioid crisis, the root causes, the solutions, and lessons learned. And I think all of these are very important. The ancient Greeks had a term called pharmakon. Pharmakon meant a medicine and a poison. And there's no better application of this terminology than with regard to opioids, because opioids can produce profound pain relief. They also produce profound pleasure in susceptible individuals. And the interaction between the two is what gives rise to this opioid crisis currently. Pain is the #1 self-reported medical reason for using drugs with abuse potential. Pain and pleasure centers in the brain are closely aligned, and many forms of pain, including psychic pain, are relieved by drugs with abuse potential. That's really important to know. The United States leads the world in prescription opioids. It is #1 compared to 30 other countries that are the largest prescribers of opioids on our planet. The average opioid prescribing in the United States is 5 times higher than most other countries, as you can see by this line. The United States leads the world in terms of opioid overdose deaths. If you look at the overdose deaths, only Estonia, which had a problem in 2012 and was cut in half very rapidly. There are other countries that are coming online very quickly now. Canada, Sweden, and certain other countries in Europe are beginning to see what we've seen. The tidal wave is moving eastward and also westward, because we're getting words from other countries in Asia. The percent of drug overdose deaths due to specific opioids is also shifting. In 2016, unconfirmed CDC reports are that it's over 64,000. The lion's share are prescription opioids, which are declining in terms of cause of death, heroin, which is still increasing, and above all, fentanyl, which now accounts in 10 states for the most opioid overdose deaths, to such an extent that police and firemen and other people within the public service community have been recruited in order to reverse the overdose. So what's happened? We have, since 2001, close to 600,000 drug overdose deaths, a 3-fold increase in opioid use disorder, and it is the addiction to opioids that's driving these deaths. The U.S. death toll is 64,000. The driving force is prescription opioids, and the transition from prescription opioids to heroin and fentanyl is a range, but it's approximately 80%. What are the root causes of this particular crisis? Generational forgetting is a major root cause. For decades, prescription opioids were avoided for chronic pain. The reasons were very simple. Physicians were trained that opioids are addictive, they can produce an overdose, and there's no evidence for effectiveness given chronically, until a 5-sentence letter was published in the prestigious New England Journal of Medicine that said addiction rare in patients treated with narcotics. They measured the incidence of addiction in hospitalized patients, and they concluded that despite widespread use of opioids, the addiction is rare in these patients. Anyone with a science degree or common sense would have known that this is junk science. Number one, how many doses did they get? How long were they on them? What were the magnitude of the doses? Were they addicted after hospitalization? How long were they used? How did they define addiction? None of these were answered. But the evidence was weak, and in spite of that, there were 600 citations, at least, to the single 5-sentence article in the New England Journal of Medicine. Almost all of them in the dark blue bars were affirmative, saying, this is right, this is accurate. Low-quality science received affirmation. What happened? It began to trigger a shift to the provider. Is that only 2 minutes left? Left? Good God. Tragedy of needless pain. Pharmaceutical companies, one in particular, spent millions of dollars in 20,000 events educating physicians and pain patients. The Veterans Administration adopted pain as the vital sign. A number of medical professional organizations bought into it, and then became the pressure for assessing pain and using opioids in treating pain. So there was generational forgetting, quality science was forgotten, pain management and opioid prescribing increased dramatically, and addictions were disconnected from treatment providers. Rehabilitation centers and the healthcare system was disconnected. Pain assessment tools were ubiquitous in hospitals and doctors' offices, and clinicians continued to currently prescribe opioids for 90% of patients who've overdosed, 90%, and they continue to prescribe high doses and in some cases benzodiazepines, which are a lethal combination. Who bears the responsibility for this? I've gone from 1 to 2 causes up to over 25 now. The poor science, patient pressure, physician advocates, the pharmaceutical companies, pain societies, the Joint Commission, Veterans Administration, the media who advocated for pain patients, poor medical education, poor patient education, rogue pharmacies, rogue physicians, and so on. I can go into any one of these. Opioid prescribing increased dramatically, and we became essentially a nation awash with opioids. With 11.8 million people currently misusing them, over 2 million with an opioid use disorder, at least 600,000 to 700,000 with heroin use disorder. The cartels in Mexico took advantage. They raised the purity of heroin. They dropped the price. Fentanyl reemerged, and we had a perfect storm. A perfect storm for this. The President's Commission on Combating Opioid Addiction met for the first time in June 16th of this year. We thought of, I decided, how do we systematize our response to this? We can go into all the factors that are feeding this. And then I said, there's another way to look at it, and that is to look at what caused this and to reverse engineer the causes. And both of these are in part in the report. There are 65 recommendations, including how we address federal funding, including prevention, including prescribing practices, data analytics, barriers to treatment, barriers to rescue, recovery support services, and research, and also combating stigma and patient education. Many of those are addressed in the report. The areas that bear responsibility are addressed. The lessons learned, I will conclude, are to scrutinize low-quality evidence, scrutinize marketing evidence suppression, engage all stakeholders, not just advocates. This is so critical. Approval of abusable drugs need broader view, anticipate unintended consequences. Medical education needs to be current. Health insurers are a critical component of this issue, and apply lessons learned to current movements to legalize and regulate all scheduled drugs. The reason I say this is that in the face of regulatory oversight, tight scheduling, nothing protected the American people. Alas, for those who never sing but die with all the music in them, weep for the voiceless who have known the cross without the crown of glory, for those 64,000 deaths. Thank you.
So again, we have time for a couple of questions before we move to the panel. I'll take the gentleman here.
I'm Harry Haverkas, retired public health service officer. If you looked at the medical marijuana and legalizing marijuana and what impact it's had, and also the needle exchange, HIV prevention, as far as its impact on drug abuse increase.
You may be aware that I wrote the World Health Organization report on the medical uses of cannabis, so I have looked at this very carefully. The best data we have, which is very current, which was published in, I believe, August of this year in a very high-quality journal, is that people who use marijuana have much higher rates of opioid use, as well as opioid use disorder. People who use marijuana for pain medications also have higher rates of opioid use and opioid use disorder. The data for long-term outcomes, the suppression of evidence that marijuana is addictive, parallels what's happened in the opioid crisis.
The woman right in front.
Hi, I'm Marguerite Cohen. I'm an OBGYN physician in Portland, Oregon. In my state 10 years ago, we were mandated to have 8 hours of pain management in order to continue to be licensed in my state because we were under-treating pain. And I need to go back and look at why that bill passed. Now they're telling us, well, now we have to educate you the other way. But I think without campaign finance reform and reform of the influence of pharma, we're not going to get to a solution.
We have 3 issues that are pressuring. The pressure is coming from pharma, clearly. The pressure is coming from pain patients. And I think those 2 pressure points help to feed the current crisis. The reversal now is really important, but what the Accreditation Council for Continuing Medical Education has found is that mandating training does not necessarily lead to practice change. and there has to be far more intricate and I would say finely tuned measures to ensure that over-prescribing does not continue. Physicians are brilliant at learning things quickly and being able to pass tests. That does not mean that they will absorb and change behavior. And there is no question in my mind that it is the nation awash with prescription opioids that fueled this current crisis.
Take one last question here, and then we'll move to the...
Yes, I can hear. I'll repeat the question if nobody else can hear you.
I'm a senior at American University, and I've been talking a lot about dentists and people, college-age individuals that get their wisdom teeth removed and get 30-day supplies of opioids being a huge part of this problem, and I wanted to know if you could talk about that at all.
Yes, we're quite aware of the problem with dentists overprescribing, and courses have to be taken by them. The DEA, in our recommendations, in order to be re-registered by the DEA, which requires annual registration, has to show that you've taken a proper course. As I said, that's not good enough. The solutions seem facile. They're one-sentence solutions. You know, increased treatment, as Sir Deaton said so eloquently, doesn't mean that treatment is going to change the face, because treatment does work in many people. But in 70% of people don't show up for treatment. They don't think they have a problem. That's what our NISTA data studies say. The same with prescribing. To say that you've taken a course and that gives you the right to prescribe Schedule 2 to 5 drugs doesn't mean that you're going to change practices. There are ways, data analytics, there are ways of excavating databases in the country that are being implemented and that we recommend very strongly to find out who is prescribing. Pharmacoepidemiologists, absolutely brilliant ones. I suggested this 10 years ago, long before the CDC guidelines. I suggested this while I was at ONDCP, that we need to recruit pharmacoepidemiologists to understand how many pills for each type of pain that is sensible. For a tooth extraction, you may not need more than 2 or 3 instead of 30 to 90.